So for this one, we're going to do the trauma patient assessment. So this could be used for our trauma patient with significant mechanism of injury. It could also be our medical patient that's unresponsive. We're going to kind of focus in on the trauma for right now. So we're going to give you a scenario. You're being dispatched for a 30-year-old male patient who is in a motorcycle accident. Patient is lying in the road. Roadway has been blocked off. The scene is safe. So we'll give you a scenario that includes that information. So when we come on, it's going to look the same as our medical. We're going to check for our scene safety, make sure the scene is safe. We're going to make sure that we have our appropriate BSI on. We're going to determine our mechanism of injury or nature of illness. For this, it was a mechanism of injury. We had the motorcycle accident, and then we have one patient. We're going to consider additional resources, and it depends on what we have. We may need law enforcement or fire for more traffic control, and then we're going to consider C-spine. In this case, because it was a trauma, as we approach the patient, I'm going to go ahead and have my partner take manual stabilization of this patient. All right, so as I come up, my partner is going to take manual stabilization. I'm going to get a general impression of my patient. So I'm looking for the patient in the scene. We have a patient that appears to be unresponsive, or we'll give him unresponsive, lying in the middle of the road. Once again, scene is secured. So I'm going to come up and determine my level of consciousness. Hey, are you okay? Hey, he doesn't respond. Okay, we'll do a sternal rub. Doesn't respond to that, so our patient's unresponsive. So once we determine level of consciousness, we're going to move on and look for that chief complaint or identifies life threats. We'll say as I do a quick kind of search down, I don't see any what I would consider life threats at this time. I don't see any blood squirting, squirting out of the body or any of that. So, so we're going to come in and we're going to assess our ABCs. So airway, as I come up, we're going to have my partner who's holding C-spine. I'm going to have them do a jaw thrust, and I'm going to assess the airway. Okay, so airway is open. We can consider an adjunct at this time with him being unresponsive. Consider an oral airway. Then we're going to assess his breathing. Just for the sake of a scenario, I'm going to say that he has really shallow breathing. Doesn't appear to be very sufficient. So we're going to switch over and begin ventilations with a bag valve mask on this patient. Okay, we continue to assess then. Ventilations are going well. No obstructions, no issues with ventilation, so we can move on to our circulation. Going to check for a pulse. With our unconscious patients, I'll typically always check radial and carotid just to make sure that that they're all matching up. And we'll say that we have a radial pulse, weak and thready. Skin color, temperature, and condition. Patient's pale, cool, and clammy. Major bleeding or any other bleeding. I don't see any other bleeding at this time. And so we're going to determine patient priority. They are a high priority patient because they're unresponsive. Okay, so we're going to start our secondary assessment. We're going to start with our rapid exam, rapid physical exam because he's unconscious. And so as we start down, I'm palpating the head. I'm going to palpate the neck, making sure there's nothing out of the ordinary, kind of looking for anything that's squishy or crunchy that's not supposed to be. Palpate the chest, so we push in and down on the chest. We're going to palpate the abdomen, looking for any tenderness, rigidity, distension, pulsating masses. At this point, I'm just going to sweep underneath, looking for any bleeding or anything on the back that would indicate that I need to roll him immediately. When I do that, I tend to go in, rake your fingers up, and then rake your fingers across the back. That way, as you're raking, you're kind of feeling for any holes in the garments or stuff that would indicate stab wound, gunshot, or anything that you're going to hook on. Because if you rake and you hook on anything, you need to roll the patient to do an actual physical assessment. Otherwise, we're going to roll him in a little bit. So we did our chest, abdomen, our posterior. We're going to assess the pelvis. We're just pushing in and down. We don't rock, so just in and down. We're going to check perineum, and so this you can verbalize, but we're basically going to sweep, expose as needed, but you're going to sweep looking for any blood, any urine, any defecation that would indicate an injury. And then as we start down, we're going to go ahead and go around the legs, looking for any of those DCAT BTLS signs. Check for distal pulses. So we may need to remove the shoes. We'll check for distal pulses. If they're conscious, you can have them wiggle their toes. Even if they're unconscious, a lot of times I'll run my finger, look for that CMS, circulation, motor, and sensation. So even though we can't assess motor because he's unconscious, we can check for sensation. You might get a response if you rub their feet. We're going to do the same to the arms. And at this whole time, the examiner will be like, nothing noted, nothing found. And then once we're down there, we're going to check for pulses. So checking bilaterally. Okay, same thing. We can check for painful response for sensation. We'll say that he has nothing. If he's conscious, I'm going to have him squeeze my fingers. Okay, at this point, we're going to roll our patient. I'm not actually going to roll him because he's up here. So we roll him. We're going to run down the back, assessing the back for any other injuries. And we'll say that none was found. When we roll him back, typically if we have our longboard, get him out of the longboard because we're going to start to get him loaded up here in just a little bit. All right, so at this point, I've done my rapid trauma assessment. We're going to go ahead and grab a set of vitals. While I'm grabbing my vitals, we're going to have our partner try to obtain a sample history. Okay, so we grab our blood pressure, and we'll say our blood pressure is, we'll say it's 98 over 60. Our SpO2 is at 95 pulse rate, and respirations, so we check it's a radial. Pulse rates is 112. Respirations are 12 with the ventilations that we're doing. Pupils. All right, so we can open up through pupils, check. Pupils are equal and reactive to light. And so we have all of our vitals. We've tried to obtain our sample history. So now we're going to get them loaded up in the ambulance and start our detailed physical exam. Once you start your detailed physical exam, you're just going to kind of walk through that process again. This time though, right, as we're going through, we're checking the head again. Right, so then we're going to palpate around the eyes, checking the mouth if we haven't already, look in the ears for any fluids. If you have your pen light, you want to look, you can. Looking in the nose, making sure everything is stable. For the neck, we're going to look at the back for step-offs. So we're looking for that spine to be out of line. We're going to look for tracheal deviation, jugular venous distension. We're going to repalpate the shoulders, the chest, pushing in and down. If we didn't up to this point, we're going to listen to lung sounds. We're going to auscultate. Okay, lung sounds are clear. Abdomen, tenderness, rigidity, distension, pulsating masses. We have nothing. The back, we can also reassess. They're on a longboard and secured down. You're probably not going to be able to roll them again at this point, and that's okay. Reassess the pelvis, looking in the groin, going back down the legs, looking in all four, looking for CMS. Arms. Pulses, sensation. Again, if they're conscious, you can have them squeeze the fingers. And then, once again, we already assessed the back. So once we're done with that, we're going to manage any secondary injuries that we find. I didn't find any. He's just unresponsive with a low blood pressure. So probably some sort of internal hemorrhaging or something going on there. So we're going to do our reassessment on the way to the hospital. We're going to reassess our primary assessment, looking for level of consciousness and ABCs. We're going to reassess secondary, looking for any changes in the physical exam. In the history of present illness, we're going to reassess vitals. Every 5 minutes, he's an unstable, unconscious patient, and we're going to reassess interventions. And then you can tell us you're done.